Thanks for being here. I'm going to call this meeting to order. This is H.R. 640. I think that's Representative Taylor calling in. Hello? Okay. Okay, again, this is H.R. 640, study committee looking at school-based health clinics. This resolution was brought to me by Polly McKinney with Voices for Children, and it looked at a recommendation from the Rural Hospital Stabilization Study Committee that we explore looking at and expanding school-based health clinics throughout the state, in that we have, a trained workforce with our school nurses, and that we need to maximize that workforce in order to try to cut down on absenteeism and keep our kids healthy and in school and learning. And I think there's a lot of merit to that. My objectives for this committee is that we can produce a report based on the information that we will gather that will be somewhat of a blueprint that representatives, both senators and House members, could take back to their school boards to look at enhancing and augmenting their school nurse programs. We'll look at a lot of different models as far as sponsorship and how these models work, and delve into some reimbursement models in order to help support this program. I did say that there was a sign-in sheet up here at the table. We'll have some presentations from some interested parties, and I'll introduce the members of the committee. Chairman Cooper is out of the country along with Polly, and then we've got Representative Demetrius Douglas coming in, and Representative Buddy Harden, and then Representative Darlene Taylor was not going to be able to be here with us today, but her representative is on my cell phone here, and we'll get her information to her. We're being assisted today by Courtney Gilman, and then my legislative assistant, Christy Tipton. If you need contacts with the committee, either one of those will be contacts for the committee, and then appreciate Betsy Howerton here with Legislative Council being on board with us. And we'll go ahead and get started. Demetrius, good to see you, sir. Good to be seen. Okay. Any other comments from either one of y'all, Demetrius or Buddy? Okay. All right. As far as the agenda, that was the introduction of members, and then we've got guests here today, and then I think we've sort of defined the objectives and goals, and then before the day's out, we'll create a timeline as far as what other action we need to take as far as additional meetings, and I think it would be important that we make some site visits to some of the successful programs in the state. Okay. I guess our first presenter is Erica Sitkoff, who is Policy and Outreach Director for Voices for Children in Georgia. And Erica has done a great job to provide the committee with a whole host of information as far as background and as far as resources there.
Yes, it's just not coming. But they have your packets.
So I keep
They have your packets, and if you want to sit down there, I'll keep it going on this, and they can just follow along in their packets with your PowerPoint.
You want me to sit down there?
Yeah, I'll keep working on this.
Okay, sure.
Whatever's comfortable for you, Erica. Okay. All right.
Okay.
That mic's on also. thank you for being here, and thank you for all your hard work to pull the materials together for us.
Oh, well, thank you. Thank you and the rest of the committee for making this issue a priority and for giving Voices an opportunity to be here today and to contribute to the cause. I am the Policy and Outreach Director at Voices. Voices is a statewide child policy and advocacy organization. So, and the audience can't see the PowerPoint, but I believe you guys have it in front of you, so I'll just say next slide when I'm going to the next one.
I've got it up now. I think it's going to work this time.
Yeah.
So, yeah, if you would rather go up here.
It wouldn't be like any other day if we didn't have technology issues, right? Okay. I'm going to be talking to you about three things today. I'll give you an overview of school-based health centers nationally and in Georgia, the need for them here in our state, and outcomes that we've seen both nationally and here in the school-based health centers in Georgia. And then I'm going to turn it over to two of my colleagues who actually oversee some of these services in our state that can give more of an in-depth view of what school-based health services can look like here. School-based health centers capitalize on the opportunity to meet kids where they are every day, which is school, to ensure that they get access to the services that they need to be healthy and successful in education. And depending on the needs of each community, those services can look very different. They could be screening for different health and mental health issues. It could be vaccines. It could be family-based services, as well as monitoring and treating chronic illnesses such as asthma. Nationally, there are about 2,000 school-based health centers, and here in Georgia, we have 9 centers with additional ones opening up this year and additional ones in the planning period, as well as 63 schools that have telehealth equipment. And again, my colleagues are going to go in more in depth in those momentarily. But school-based health centers can have an impact more on just students. In many centers, the faculty and staff at the school benefit from those services as well, which help keep teachers in the classroom. Families benefit from them, as well as in some cases, members of the community. This slide gives an overview of what funding looks like nationwide. What it looks like here in Georgia currently is that foundations and grant support help with the startup costs, billing to insurance, most of the time through federally qualified health center sponsorship for the services that are provided, as well as in-kind support for operations. But as you can see here, there's a wide array of options that Georgia can tap into to think about how to build the startups of school-based health centers and sustain them over time. So Georgia is consistently ranked in the bottom 10 nationally for child well-being, and quite frankly, a lot of this has to do with the access to ongoing health services. As you can see here, we tend to hover around 50 to 60% in availability, everything from children having access to routine health visits by having a medical home, mental health services, and dental and oral care. Now, this number of 200,000 children uninsured in Georgia now is actually a lot better than it was 10 and even 5 years ago. We've made significant headway in ensuring kids are insured. However, if we flip the switch today and all of a sudden every child in Georgia had health insurance 100% of the time, would that mean that they had access to the services they need? And the answer is no, quite frankly, in many of our communities, especially our rural communities. 63 of our counties do not have a pediatrician. And if you look at the recommended best practice ratio of mental health workers, you'll see that we are, in many cases, much larger in what is recommended as best practice. Even when you look at the resources that are designated to schools, you can see here that the ratio of our school social workers is 1 to 2,742 students, and the recommendation is 1 to 250. So need to find a better way to coordinate all of the different resources that we have to ensure that they're getting to the students. And the disconnect between need and resources, whether it be acute or chronic conditions or mental illness, have a direct link into the educational outcomes of our students. The average absences for a student can nearly double for children that are experiencing mental health challenges. Asthma and oral health are leading causes of student absences here in Georgia, and those numbers look even worse for children who are living in poverty. We know that the more time children are in class, the more likely they are to read on grade level by third grade, and the more likely they are able to read on grade level at third grade, the more likely they are to graduate. So we need to find a way to keep kids healthy and keep them in class. There we go. So how do school-based health centers help us do that? And we've seen that in communities and schools where children have access to a school-based health center, there's decreased hospitalizations for asthma. There's an increased use in primary care, increased use in mental health services, increased use in the treatment and monitoring for asthma. We see results in education as well. Decreased tardiness, which basically means increased seat time for kids. We see both nationally and locally an increase in attendance in our Lake Forest site, which again, my colleagues will talk a little bit more about the actual data that we're seeing. But when kids have access to health services at school, they are more likely to be able to return to class versus missing an entire day or multiple days. There's a little bit of a delay. Okay. Cost savings. There are cost savings associated with school-based health centers. We've seen this both nationally as well in our sites in Georgia, where there have been a reduction in Medicaid expenditures for children that have access to services, health services in schools. And you'll see some examples there. So the big picture, what does this all mean? We know here in Georgia that school-based health centers help get children where they need to be in terms of being healthy and educated. And that's what, we know that that's what they need in order to be successful adults. And any questions on that overview?
Erica, thank you very much. And I think there is a parallel study committee that Chairman Dempsey is doing, and that's looking at child mental health issues. And I think one of the values of the school nurse is if she is repeatedly seeing a child over and over again, it is to start the conversation. Is there something happening at home? Is there a problem? And then also as a referral, if they're going to be referred for other services or in need of other services, to at least start the conversation if they're repeatedly seeing a child over and over and over again, that there's some underlying cause for those repeated visits and to the school nurse.
Absolutely, and I believe we have someone who signed up to speak today from the nursing community who will speak to some of that as well.
Certainly. Okay, buddy. You're 20.
Yeah, I was just wondering, even one is too many. If with 320,000 students missing more than 10 days, do you know, are those in different areas, or are they spread throughout the system? I guess what I'm trying to say,
geographically.
Do we have geographical areas that are worse in that area?
Yes, we have that information. I'm turning to the Assistant Superintendent of the DOE. We do, and I believe we can get you that information.
I think that would be good information to have, and,
okay.
and it might show us where we need the most work or the earliest work, I guess it was.
Excellent point. Yes.
And I know from my experience at home that there is a continuing underlying problem as we are still pulling out from the Great Recession, is that the underlying problem we have, if we look at the high number of free and reduced lunches in the school systems across the state, the underlying problem is just flat poverty.
Mm-hmm.
And you know, as we continue to progress, I think that's something else that we will need to take into consideration, is just the fact of just poverty.
Yes.
Erica, thank you very much. Any other questions?
Thank you very much.
Demetrius, you got any questions?
No.
Okay. Erica, thank you very much for your work.
Thank you for the opportunity. If any other questions arise, we are here to be helpful and provide information, and we will work with the DOE to get you the information on student absences.
Thank
Okay,
you.
great.
Thank you.
All right. And I appreciate them being here today. Okay, our next presenter is Dr. Vita Johnson. She's the Director of Partners for Equity in Child and Adolescent Health. Good to see you again, Dr. Johnson.
Good to see you. Good afternoon. I represent Broderick and the committee and family and friends. I apologize for being late. I was in clinic this morning, so I was like rushing to get here. So I think I have my presentation somewhere. It's interesting that you brought the whole issue of poverty, because we realize that children who live in poverty have just really poor outcomes across the board, both academically and health-wise and socially. And the beauty of school-based health centers is that the value is that it really is probably the best method of providing health care for underserved children in this country. And I say that because I've worked at every system you could possibly work in: community health centers, hospital-based, private practice even. And your capacity to see children in the context of everything that affects their lives, and your capacity to see them always say in the raw. You get to see them as they get themselves ready to come to school without supervision from their parents. You get to see the conditions under which they live. You get to see the interaction between the child and the school and the parents in the school. It's just really an extraordinary way to deliver health care, understanding that your purpose is to improve the academic success of these children. So the whole issue of poverty, the fact that we are, you know, we have the highest poverty for children. The fact that the United States of America, you know, ranks 34 out of 35 countries in childhood poverty really speaks to that problem. And until we can sort of address that with economic developments and, you know, all that goes along with it, like education, we're not going to get rid of that cycle. Oh, okay. Yeah, I can. It's just taking a while to pull up?
Yeah.
Okay. Okay, so I can do that. Okay. Am I going to do...
It's just trying to...
It's just... Okay.
It's just gonna take
Your computer is like my computer in the hospital. It's kind of slow. All right, so I know Erica has talked about this whole association between health and education, and, you know, I just have to reemphasize it. It's key. You know, children they can't learn well if they're not healthy. They can't learn well if they're not present, if they're not sitting there receiving instructions. They can't learn well. Oh, there it goes. Well, it may take a minute also, right? Okay, so it's coming. There we go. They can't learn well if they aren't socially and emotionally connected to the school. There are a lot of studies that have come down the pike over the past few years that realize children really need to be connected to the school in a very important way. And children can't learn well if there's not hope. And sometimes people look at you funny and say, well, why are children hopeless? It's amazing the number of children who come to school who are in this country who really experience a high degree of hopelessness for a lot of different reasons, and poverty is one of them. So we always ask the question, why are school-based or why are school health programs important? And we talk about the association and that you really can't educate a child unless he's healthy. And then there are many programs, there are many instances of school health programs that start maybe just with the school nurse, and school nurse is integral even with the development of school-based health centers, but there needs to be some sort of healthcare provider in the school to address all the complex issues that children bring to the school. And historically, you know, teachers have actually served in that position. They are not only instructors, but they actually are mothers and counselors and medical providers, and they have to do all of these things, and they really do need that ancillary help in order to teach the children. Yeah. I want to throw out again where we rank. We rank 40th. We've actually improved. We ranked 42nd up until this year. Now we have actually come up a little bit, and we rank 40th in overall child well-being, 43rd, which we've remained stable in poverty. We've gone up 37th in child health, mainly because of preterm deliveries and adolescent suicide. And we rank 40th in overall education and 40th in family and community support. And if you look at states that rank first, second, and third in overall well-being, guess what? They rank first, second, and third, fourth, fifth in education and also in health. So there's a huge correlation between health and education. Talk about childhood obesity because we always throw that out. Actually, we've done a tremendous job. We had the second highest childhood obesity for a very long time, second only in Mississippi, but now we're up to 17th. So we've done some really good stuff with that. We continue to lag behind the country in adolescent depression. We rank 29th. 29% of our children experience some sort of depression in the 12-month period compared to the rest of the country, which is 27th. And you think about that, it's pretty extraordinary that a third of our children experience some form of depression, which speaks to the whole issue of mental health. 26% of our children live in poverty. A large number of our children are uninsured. And over 300,000 of our children miss more than 10 days of school because of illness. And as you transfer the health issues into the education, everyone knows that we're doing very well with our fourth grade reading, and we have a tremendous interest throughout the state in improving proficiency by fourth grade. It actually decreases as we get to the 8th grade, not quite sure why that happens. And in math, we don't do a whole lot better. As far as high school graduation rates, we've done better. I mean, we've come from the high 60s to almost 72.5%, which really speaks to the educational system and the efforts that are being made, and they need to be commended for that. But still, more than 10% of our children are absent 15 or more days from school because of various issues, and the majority of those issues are because of their health. If you look at the interface between health and education, we know that that poor school performance is linked to a lot of health-related issues such as hunger, physical and emotional abuse, and chronic illness. And as I developed our school-based health centers, it was amazing to me 20 years ago, the number of children who came to school hungry and the number of children who left and didn't get a meal till they came back for their breakfast in the morning. And so with the recession and the elevation of food insecurity in this country, that's even worse now. We know that poor academic outcomes are linked to a lot of risky behaviors, especially in our adolescents, around substance abuse and violence and physical inactivity. And all of those things affects the child's attendance, grades, more importantly, their ability to pay attention in school. I always say that education is a direct predictor of health. So as physicians, there's no way that we can expect for our children to maximize their health unless we help them to achieve academically. And that's one of the things that we teach our residents at Emory, is that, you know, you go into the room when a child is born, you have to help these families maximize the learning ability of their children by helping them to maximize brain development. And that really is very simple. You just read to a child, you sing to them, you hold them, you show them the environment in which they live, and you just inundate them with words and experience. So that starts when they're born, but we also monitor these children as they enter school to see how they're doing. So you go in, I had 2 or 3 grade level children this morning, and the first thing I ask them is, so how are you doing in school? And they usually say, oh, I'm doing okay. I said, no, what did you make on your last report card? And then they'll say, well, you know, I didn't do too good. Or they say, I made all A's. And then, you know, that really motivates me to encourage them to continue to do what they're doing. But then when I find children who aren't doing well, then I try to figure out how we as a medical entity can help facilitate this relationship between the school and the parent. Because oftentimes children do poorly. When children do poorly, their parents have done poorly. And oftentimes parents don't know how to engage the educational system because they're intimidated by it. And so they need someone to advocate on their behalf and to help them understand that you need to be the person advocating for your child. And so as physicians, it's really critical for us to be really engaged in the academic success of our children, especially if we want to maximize their health. Okay. So what do we know about this interface between health and education? We know, based on the coordinated school health program, which some of you may be familiar with, that was developed by CDC almost 20 years ago, that school health programs and policies can really be an efficient way to prevent or reduce risky health behaviors and avoid serious health problems among students. The school nurse is just critical. It really is. The school counselors are critical. All those who care for children. And the school-based health center is just an adjunct to the work that they do and an expansion of the work that they do. And we also know that the school health programs may help to close this educational achievement gap that we see between the disparate socioeconomic groups of students. So when I talk about school-based health centers, I want you to focus on 5 key descriptives. One has to do with the patient and community focus of school-based health center, the fact that school-based health centers are accessible and affordable, the fact that they provide comprehensive care that is of high quality, the fact that there's this wonderful multi- and interdisciplinary approach to caring for children that brings in not only the school-based health center staff, but also the school counselor and the school nurse and those that are also providing the care for children. And that we really focus on outcomes, that we really want to improve the outcomes of children. We're not there just to see them and say we see them. We really want to affect their academic achievement and whatever health issues they may have. So I'm going to give you a quote by someone who's really been involved in the school-based health center, me. So I actually wrote this. And I said that school-based health centers represent the most effective system of care for the underserved in this country. It is a system of care that essentially eliminates every barrier to health care, whether it's cost or hours of operation, transportation, or access. And the holistic, multidisciplinary approach to providing health care is very effective in addressing health disparities in the context of the social determinants of health. In addition, school-based health centers provide services in a coordinated, integrated manner where all providers are operating under the same roof and in constant communication with one another. It embodies the quintessential team approach to providing health care. This efficient method of service delivery impacts not only the health outcomes of patients, but improves student attendance and achievement, and significantly reduces the cost of health care to the state. And I really believe that. So if you look at the definition of school-based health center, there are many out there. As a matter of fact, the School-Based Health Alliance, which is the national alliance, is actually trying to come up with a different definition that really captures all of the services provided through school-based health centers. But right now, the definition is basically that comprehensive school-based health clinics are medical centers. They are independent centers that are operating within the confines of a school that blend not only medical care, but preventive and psychosocial services, as well as organize broader school-based and community-based health promotion efforts, and includes the following essential components. They are located within a school building or in close proximity. There is provision of comprehensive primary and mental health care, and there's a tremendous interrelation of family, school, and communities. And I can give you tons of stories about how we can bring families into the school, basically because we're addressing the health of their child. And I can go into that deeper if you like. Okay. Pardon? You like to hear that? Okay, so a short skim. Okay, so I'm just going to say this. So health is neutral, right? Parents really are not, they're not put off by medical providers because they don't perceive us as blaming them for whatever's going on with their children, right? So if a school social worker comes to the house, or a truancy officer comes to the house, or a teacher calls you up, then the parent immediately becomes defensive because they think, okay, what have I done, right? But when they bring them in for health, it's just an interesting phenomenon. They see us focusing on the child and not them, and so they have a tendency to want to come and participate in the care of their child. So while they're there, if you hadn't been able to get them in for, say, a teacher conference or whatever, which happens all the time, it just so happens that the teacher knows they're coming, and they sort of come by the clinic, and then, you know, you say, oh, there you are, and then you kind of bring the families and the teachers together. Another thing that I've done is that children who have really significant issues, especially psychosocial issues, we do psychoeducational testing on these children. And so when we are going over the report, we can bring the teacher and the parent together. And we sort of facilitate the discussion between a parent and a teacher who normally are at odds with one another because the child hasn't done well. And so once we have everyone focus on the child, it really does change the dynamic of how they relate to one another. It's the most amazing thing I've ever seen. I used to call it my wailing chair because at the end of my sessions, everybody would be crying, you know. But it was a wonderful, and I didn't understand the value of that until I actually started school-based health centers. So that's sort of it in a nutshell. Okay. You're welcome. So there's some common features of school-based health centers. First, as you can imagine, they're located in schools of close proximity. The health center works cooperatively within the school to become an integral part of the school, and that's really key. Is, you know, after we had started our first school-based health center, after about a few years, everyone thought I worked for the school system and not for Emory. And so you really have to integrate your work into that of the school system and abide by the rules of the school system. The health center provides a comprehensive range of services that meet the specific physical and behavioral needs of the children. And as I said before, it's this wonderful multidisciplinary approach where the school nurse is there. I always call them the anchor of the whole program, along with the clinic staff and others who work to care for children within the school. Okay. This is slow. The services that are provided, like I said before, are provided by an independent health system that comes into the school, and it's not the school itself that does it. I just want to emphasize that. The school is not responsible for these health services. It's an entity that comes in that has a memorandum of understanding with the school district and it agrees to abide by all of the regs and the policies of the school, and everyone understands what their role is. The parents must sign a written consent, which is fairly comprehensive because oftentimes the parent's not there when you see the child in order to enroll them and to see them. And the health center, which I think is really important, has an advisory board that consists of not only the people who provide the services, but also the community and the parents as well, so that they can monitor what they're doing and adjust as they go along. Okay. You guys got to get this fixed. Okay, so there are 7 basic principles to school health. One is, first, that it supports the school. It supports the school. It supports the school. The whole purpose of being there is to allow people to educate their children and allow teachers to do their work well and everyone else. It responds to the community, because I'm going to go a little bit into how it's important to have the community at the table of planning before you even start a school-based health center. It focuses on students, develops comprehensive care. It advances health promotion because you can do a lot of health promotion. You can go into the classroom and actually reduce risky behaviors as children get older by teaching them how to develop healthy habits. And it provides leadership in adolescent and child health. So the scope of health care, health services provided by a school-based health center is determined at the community level. We always say if you see one school-based health center, you've seen one school-based health center, because it should reflect the needs and the values of that community. And so the services are basically the same, but it still should reflect what the community said needs. So the first, it should provide primary care for acute and chronic health problems. Mental health problems, as we've stated before, is incredibly important. Substance abuse for those in the middle and high schools, case management for at-risk children, dental services, nutritional service, and health education and promotion. And the services, as I said, are determined through a collaborative effort between the healthcare organization, the school, and the community. Nobody does it in silos. Nobody does it in isolation. The services reflect the healthcare needs of the children in that specific community and supports the values and the regulations of the community and the school system. And I always say that they should be provided in the basic principles of the patient-centered medical home. Now, as a pediatrician who started school-based health centers, that's my approach. Now, there are many school-based health centers that really don't have the capacity to serve as a medical home, and they don't have to. But there are some that can, and when they can, especially in rural areas where you have so few providers, it's probably one of the best ways to provide sort of a patient-centered medical home for children. So the staff that we normally see primarily is a medical provider who's usually a nurse practitioner or a physician assistant. We usually, if you're fortunate, we'll have a social worker, a licensed clinical social worker who can do social work as well as provide mental health services for children. And you can also have a medical assistant. If you have a medical assistant and a nurse practitioner or a PA, you can do pretty much anything you need to do. And then if you throw in a licensed clinical social worker, it just really completes that loop for you in providing the health care that children need. And then there are options. You can have community case workers who go out and engage families. You can have a dentist or dental assistant, hygienist, and a health educator, all of which we had at our first school-based health center here in Atlanta. And I invite you all to go and actually take a look at that center, because it's probably, we all call it the Lexus version of school-based health centers. And it is, but the ones that just have the nurse practitioner and the medical assistant can do an extraordinary job. And that's a model that we have in Albany that you can see as well. So we know that research has demonstrated the effectiveness of school-based health center. They've been around for, almost 40 years. There's been a lot of research that I won't go into in any detail, but we have demonstrated that there's increased access to health care with these centers. There's improved health outcomes, especially with children with chronic health problems, asthma, obesity, behavioral health problems. It really decreases the cost to the state's Medicaid system, and we wrote a paper that demonstrated that almost, I guess, 10, 15 years ago. And it improves school attendance and academic performance, and we've been able to demonstrate that with the school-based health centers that we've started in Georgia in the past year or two. And this is my paper. I won't go into it, but if you'd like to see it, I'd be happy to send it to you, and you can read through it. So nationally, as Erica said, there are over 2,000 school-based health centers. They're really closer to about 2,400. They're getting ready to do their census. Actually, to complete their census, it's a triennial census that they do. So at the last one, there were 2,000. Most of them are in the urban areas. There's some in the suburbs and rural. For 15, 16 years, there were only 2 school-based health centers in the state of Georgia, and they were the 2 that we started over in Edgewood Community at Whiteford and Cohen Middle School. There were others that really wanted to and actually got started. There was one in Columbus who tried to get started but couldn't sustain it. There were some even in Atlanta that were supported by Hugh Spalding that really couldn't sustain themselves. But we were able to sustain ourselves mainly because we were federally qualified health centers, and I'll talk a little bit more about that. Uh-oh. I don't know what that was. We'll just go to this one. So the development and expansion of school-based health centers has 4 basic elements. First, you have to recognize community need and support. You have to increase public will around school-based health centers. You just can't go into a community and say, okay, let's do a school-based health center. The community has to come together to determine whether or not this is of value to them. It has to be sustainable. You have to come up with a model that can really sustain itself. You have to have evidence. Okay, that switched on its own, but I remember it. You have to have evidence of need and support, and you also have to be sort of loyal to the model that you know that works. And that's how you expand school-based health centers. You have to have those 4 elements. So expansion of the school-based health centers in Georgia, like I said, we only had 2. Our goal as an organization, Partners for Equity in Child, Adolescent Health, was to expand school-based health centers to 10 over a 5-year period. Our Partners program, our goal is to increase access to health care and to improve the delivery of health care for underserved children in the state. And we do that by the expansion of school-based health centers, by creating family-centered approach to caring for children at Hugh Spalding, by advocating for academic success for children starting at infancy, and also we focus on training residents so that they can do a better job of caring for the underserved or caring for people in the context of social determinants. So our goal was to expand from 2 to 10 over a 5-year period. Uh-oh. And so we started off with a planning phase. We gave planning grants to counties throughout the state of Georgia for them to come together over the course of a year to bring together every stakeholder who cared for children, whether it was the school system or healthcare providers, or we always call them matriarchs or the patriarchs of the communities, or politicians, bus drivers, defects, the people who swept the floors. We didn't care. We left it up to the communities to bring together stakeholders so that they could first identify the needs of their children. Because even though they're very similar across the state, there are some uniquenesses, especially in the rural communities, around the needs of their children. So first they were to do a very comprehensive needs assessment, and then they were to continue to come together to come up with strategies to address the needs of their children, hoping that school-based health center would be one of their solutions. We brought them up to Atlanta 3 times throughout the course of that year to do workshops, one around school-based health center one-on-one and marketing. We also brought them up to do business planning, and then we brought them up at the end of the year to share their successes and their challenges with one another and to serve as networking. And so as a result of that, we have given 29 counties, which represent 34 communities, because one of the counties in Dodge had a consortium of 4 other counties who worked with them, and so they could use the grant to actually to do the planning for 5 counties. And we're scheduled, and so we've worked with 34 counties, and we're scheduled to fund 4 more this year, starting at the end of this month. The implementation phase of our program really started, well, a lot of the school-based health centers at the end of the planning year really were in the position to actually start a school-based health center, just didn't have any funds to do it. And so we had to come up with funds in order to help them get started. So that really started our implementation phase of the program. So in October of 2012, Healthcare Georgia Foundation gave us a grant, and we were allowed to fund 3 sites throughout the state of Georgia. One was up in Catoosa County in North Georgia, in Albany in South Georgia, and here in Atlanta at Lake Forest. And it's interesting that in Catoosa, the majority are white children, in Albany, majority are black children, and in Atlanta, the majority of children are Latino children. So it's an interesting diversity among these 3 sites. And you can see the names of these centers. And we partnered with federally qualified health centers because remember I told you to expand, you've got to only get community need and buy-in through planning, but you also need to be able to sustain yourself. And we find that FQHCs have the greater capacity to sustain these programs for reasons I'll talk to in a second. So the process of the implementation required that you get your district and your school engagement along with the school board approval. You have to identify space for the school-based health center within the school, and then you have to have time to renovate that space. In some of these centers, the school system, like in Albany, agreed to renovate the space. We don't ask them to do that. Well, we do ask them to do that, but we don't insist that they do it. But at the other 2 sites, the healthcare organization renovated the space in order to provide the services. Up in Catoosa County, they actually bought a modular unit and put it right next to the school and used that as a means of providing their health care. Their school-based health center sponsoring organization has to hire their staff. They have to, if you use an FQHC, get a change of scope for services. You have to get Medicaid certification and staff credentialing. And, you know, that takes a while to do that, but all of them were able to get started within 3 to 6 months, even after the dollars came in. And then you have to really work on student recruitment and enrollment and outreach to families. Really, you should start that even before you even start your first day of school, because that goes along with that whole planning process where you're engaging families and communities in the value of school-based health center. And then you have to develop your advisory group, which usually is a continuation of those who are on your planning advisory group. So as a result of our implementation and planning phases, we've developed 6 new school-based health centers throughout the state of Georgia. And as I said, 3 were established through a grant provided by Healthcare Georgia Foundation. Some of them, one of the FQHCs decided they wanted to do it on their own and expand their services to a high school here in Atlanta, North Clayton High School. And we didn't give them any startup dollars for that, which we thought was great. If you look at the centers up in Catoosa, they're going to start another school-based health center because they have a new access point grant and they can do that. And the folks down in Albany are going to start a second school-based health center out of their own budget because they know they can sustain themselves. So it's been really effective, this whole planning implementation process. I said we had several of the schools, especially in South Georgia, who've decided to do telemedicine. I said 40 plus, but I guess we have more than that. And the issue with telemedicine is that it's a wonderful adjunct. It's just that you need to develop your system first before it really becomes effective. But they can provide some good services for children. But if you don't have your system first, then the equipment is like putting the cart before the horse. You really can't do your work well. And we have 5 new sites, like I said, that are slated to open this year in addition to the 6 that we already had. And if you can see the map, you can see these are the places where we have comprehensive school-based health centers, those that are in existence and those that are slated to open this year, and those that are in the process of working with local providers to get started. And so we've really come quite a way since we started 5 years ago. I just want to say a little bit about sustainability. So in 2014, Healthcare Georgia gave us another grant, and really we were to focus on sustainability. And all 3 of the sites did an extraordinary job in trying to get to the point of being sustainable without other grant funds. But to do that, you really have to develop really good partnerships, especially with those in the communities. And that's why I love the whole issue of the planning grant and bringing all of the stakeholders together. Everybody can contribute to this, and you can sustain yourself within a community if you can figure out what other people are doing and how you can work together. There was clinic outreach and marketing in order to get enrollment. I'm really strong on quality care. And so we had benchmarks around asthma and obesity and health maintenance for these children that we expected these centers to abide by. And that you have to have a very strong business model. You got to, really be efficient in your billing. You got to make sure these children who are eligible for Medicaid are on Medicaid. And you've really got to, do your due diligence in finding out what the resources are for reimbursement. So they developed budgets for these school-based health centers, and these benchmarks for clinic utilization and patient revenue were established during the sustainability phase. And they did an effective job. So I just want to say a little bit about FQHCs. Why are they good at being sponsors for school-based health centers? Well, first, it really aligns with their mission. Their mission is to take care of the underserved, right? And they get federal dollars for that. But more importantly, when you bill, you get enhanced Medicaid reimbursement for the services that you provide, so that also lends itself towards your sustainability. But also they have access to new federal grants. They have access to federal dollars that no one else has access to. New access points, so they can start services at new sites. They have expanded services grant where they can expand to mental health and oral health. And so they really are sort of the optimal healthcare system to sustain school-based health centers. There are many healthcare organizations who do an extraordinary job. They may be hospital-based. They may be some private practices. There's a private practice in North Carolina that controls about 10 school-based health centers because they see it as an extension of their work into the community. But everybody sort of struggles with the sustainability because you're taking care of underserved children, right? And then sometimes you have children who don't have any insurance or any coverage, and so you still have to provide care for them. So the best model are for those systems that already have that charge, who are already committed to taking care of underserved and have the resources to do that. So nationally, about 40% of school-based health centers are actually sponsored by FQHCs. I just want to show you just pictures of the school-based health centers that we have. So this is Turner Elementary in Albany. This was their opening day in March 2013. This is Lake Forest here in Sandy Springs. They opened in May 2013. These are our folks up in Tunnel Hill, Georgia, in Catoosa County. They're extraordinary folks. Like I said, they're getting ready to open a center in Walker County. That was their first patient, by the way, with no teeth. And this is North Clayton High School here in Atlanta that opened in January of this year. So just to end, I'll talk a little bit about evaluations. So we're a medical institution, right? Academic institution. We're all big on evaluations, And actually, I point out that actually I have an NIH grant that really, the purpose is to look at how school-based health centers reduce health inequities in children. But as part of the implementation and plant and sustainability grants, we wanted to ask a few questions. And they were, how do school-based health centers increase access to health care? What's the impact of school-based health centers on the management of asthma and obesity for identified patients? What's the impact of school-based health centers on receiving their health maintenance, their scheduled health maintenance and immunizations? What's the impact of enrollment and utilization on school-based health centers on school attendance and seat time? What actions are taken by the school-based health centers to sustain themselves, and what is the impact of utilization of school-based health centers on reducing the cost to the state Medicaid system? And just to give you some, briefly, some of the results of our evaluation, we saw that you could increase access on all three of these clinics. They had over 80% of their children enrolled in the center in the first year. You just don't do that. It usually takes 3 years to get 70% of your children enrolled. But the fact that they had that whole planning year and they were able to engage community and get good community buy-in, they had over 80% of their children enrolled in the school-based health center. And as from year 1 to year 2, you saw more children utilizing the center, which increases the access. And that's just a graph showing how you increase the utilization from year 1 to year 2. What's the impact on asthma and obesity? Well, when we look at asthma, we have certain health standards for children. Those who have their asthma action plan, those who have the severity of their asthma documented and they are treated appropriately, and those children who go to the ER or hospitalized because of their asthma. And we saw really good results in all three of those categories. On health checks and immunizations, we saw the folks at Turner were just really extraordinary. What they were able to accomplish was really phenomenal, even for us who were monitoring them on a regular basis. But they had significant outcomes in the number of children they were able to do health checks on, the teenagers that they were able to give their immunizations on, which we know is a real problem in our state or throughout the country around adolescent immunizations. So they excelled in all of those. And all of them, actually, for those children 0 to 6, those children who entered those centers were fully immunized. And then finally, if you look at seat time, Lake Forest was the only school that actually looked at seat time because the way that the nursing techs report to the school district, they were able to look at the number of children who actually entered the school clinic where the nurse tech was the year before the school-based health center and evaluate the number of children who were sent home as a result of that because they, were sick and they had nowhere else to go. The first year of the school-based health center, they were able to reduce the number of children sent home by 44%. Which is really extraordinary. And then the second year continued at about 38%. So increase in seat time was tremendous at this school. I know it was tremendous at the other two sites. It's just that the school districts don't report out the way that the folks do at Fulton County, and so we weren't able to look at that. Well, at the first year, when you look at overall attendance, they were able to reduce absenteeism by 10% at Lake Forest as well. And that sort of gives you a chart of the increase in seat time. And also, for those children who were sent home, it was extraordinary. On year 2, the number of children who didn't miss any days of school after they were sent home just went up by, about 60 or 70%. So even though they're sent home, the healthcare needs are taken care of, and they can come back the next day. And so the number of days that they miss were reduced tremendously because of the school-based health center. Okay. And let me just talk a little bit about startup and what it costs, and this has to do with sustainability. So we've always estimated that the average school-based health center, the startup cost is about $200,000 to $250,000 per site. The majority of that has to do with personnel, and this personnel, if you go up to 250, really takes in consideration staff and a nurse practitioner, a licensed clinical social worker, and a medical assistant, all right? But the reality is the majority of folks don't have those resources, and they usually start just with a nurse practitioner and a medical assistant, which reduces that about $50,000 a year. You have to invest in medical equipment and office equipment the first year that isn't carried over into the second year, but the medical supplies are still basically the same. So and also during that year, there's a nice value to the in-kind services from the school. So the school nurse who works in conjunction with the school-based health center, that we kind of factored their salary in, even though the healthcare organization isn't providing those dollars. And also the space, what it takes to give the space for free, for utilization and just the use of that space. Those amounts came to about $170,000, but that's in-kind service, and those continue. If you look at year 2, you reduce that amount by $150,000 to $200,000, and the in-kind is basically the same. So if you look at, finally, the state's investment in school-based health centers, we know there are 18 states that invest in school-based health centers. Last year, the amount, in 2011, the amount was about $90 million was invested in total investments in school-based health centers, which covered about 875 school-based health centers from state funding. And this amount has increased significantly since 1996. If you look at the funding sources within the state, $60 million comes from just general state funding, $9 million from tobacco settlement, about $6 million from MCH grants, and about $15 million from other sources within the state. But there is potential return on investment for our states. And they are basically what was proven through a lot of our evaluation and research, that when you invest in these school-based health centers, you do increase access to quality health care for children, you improve health outcomes for them, you decrease the health care costs for the state as a whole, but most importantly, you improve school attendance and academic performance. And with that, I'm done.
Dr. Johnson, thank you very much for taking out of your busy day to be here with us and for being such an advocate for the children of our state. I appreciate that very much. And I was just sitting here thinking, one of the sort of obvious advantages to school-based health clinics is addressing the disparity of access.
Yes.
You've got a captive community. You've got a captive population. You've got them there 8 hours a day.
That's right.
So they are right there.
That's
So
right.
it's not transportation or anything else in order to have them there for the clinic. Any questions from the panel? D? You guys? Okay. Thank you very much.
Okay.
Appreciate you being here.
Oh, you had a question?
Okay, Buddy's got a question. Buddy's got a question. Okay.
Okay.
He's got some.
Yeah, thank you very much for the presentation. I tell you, some of the questions I'm asking are strictly because of my district
Okay.
and the poverty level, as I mentioned before. The cost of this, and I noticed the state invested some $90 million. Is that correct? $89.6 million.
The state, yeah.
Yeah.
That support that.
All right. The cost to a school system, and I know it depends on the number of students, et cetera, but our problem would be, I've got one county that their eSplost only raises $30,000 a month. And there's no way those smaller communities or the ones with a high level of poverty are going to be able to fund, I guess, this type of operation. What do you have any ideas for where those people can go to get? Because I think this is great. This is a good presentation, and it's a fantastic idea. And I think healthcare wise, it would solve a number of problems, and like appearances, emergency rooms, and overutilization and costs to the healthcare system in those areas. And it definitely would improve the quality of education because the students are going to be more capable of learning. But do you have any ideas on how we go about finding the funds to make this work?
Right. So remember, school-based health centers, the activities are not dependent on the school system to support it, right? Only thing we ask from the school system is space. So the healthcare organization that comes into the school to provide the services, they're the ones who have to come up with the money, right? So the burden is off of the school system around trying to come up with $200,000 to provide these services. So that's why I talk about FQHCs. So in the state of Georgia, we have probably fewer number of FQHCs than any other state in the union, right? We have now 31, I think, 31, 34. But what's interesting, though, if you look at the map, which we've pulled out, if you look at the map of the state of Georgia, it's fairly saturated, not saturated, but a large number of our 159 counties are covered through the school-based health centers. A lot of them have 8, 9, 10 satellites throughout the state. And providing health care for children is really a priority for them, mainly because, I have to, like I said, the mission aligns with what they're trying to do, but the reality of it is children are insured. Children have Medicaid for the most part. And so it really helps them as well, right? So when they are able to see children and bill for Medicaid, they get enhanced Medicaid reimbursement, and they can actually sustain that work. And so we have been working with all the FQHCs throughout the state to just educate them about the value of school-based health centers and see if they will be interested. And we've been able to partner the FQHCs with a lot of the counties. And some of the counties that are in the planning phases are actually in the process of talking to the FQHCs to see if they will come alongside, come into their county, if they're not already there, and set up a school-based health center and actually be responsible for the cost. So it's not on the school system at all, never is. Now, I have to tell you, there are some school-based health centers throughout the country, like the ones in Connecticut. The school system supports them to a certain extent. But the rule is that the healthcare organization provides the funds and actually supports the school-based health center.
All right, so the $90 million in state funds, then what did that go toward?
So we're talking about startups. We're talking about a lot of these centers can actually go in earlier and do the work to the point they can get up to sustaining themselves if they have startup funds. And so our mission really is to try to find as many organizations or the state itself that would actually supply startup funds for these organizations, and then they take it from there.
All right, and do you know where the state, or is there a line item, I guess, in our budget for this startup?
In our budget?
In the state budget.
I like for it to be.
Well, we spent $90 million. So
no. So you talking about the $90 million I had on this report?
Yeah.
No, those are the other states. That was
those
are the other
Okay.
18 states. No, it'd be great if we had $90 million, but actually we only need about $5 million. But our goal really for the committee is to look at the value of it and see whether or not it'd be a great investment for our state to make.
Okay.
Again, thank you very much, Dr. Johnson. I
Okay.
appreciate you
You're
being here
welcome.
today. Thank you. Pat, did you have any questions? I didn't introduce Pat Gardner, who is here as representative, just as interested party. Okay. You got a question?
I do.
23.
I'm just trying to figure out how the relationship with the FQHCs and telemedicine, both of them work. Do they have telemedicine, I guess to start with, do they have adequate connectivity to a telemedicine center? And I know I sound like a broken record, but when I went to Chez telemedicine place and asked them what their referrals were for, 75% of them were for psychiatric care, and they had one psychiatrist, and it was a long wait time, which really kind of undoes the purpose. So is telemedicine a good option for these clinics? And I mean,
Yeah.
where are the centers? How can you make that piece of it work?
So I do think telemedicine is a good option. I think, though, I think telemedicine needs to be a part of a healthcare system. And I think the problem that we have is that a lot of our schools who have telemedicine are not part of a healthcare system. And so they're not effective. The FQHCs, when I talk to them, I say, you can use telemedicine as a great adjunct. It's wonderful. Behavioral health, subspecialty care, I mean, it's just like extraordinary when it comes to that.
If they have the professionals, right?
Right, but you got to have the professionals. So and also you can use telemedicine to link schools, right? So if you have services in one school and you need to connect with other schools, like in Ware County there are like 10 schools that have telemedicine equipment. In Coffee County there are 11 schools that have telemedicine equipment. In Berrien County there's 3 schools who have it. So there are a lot of them who have it, but they don't have the capacity to see the children because they don't have providers who are committed to providing these services.
So what about the health department? The health departments are supposed to have health clinics, do they?
Is Salima here? Oh. So I know the health department does a lot around teledentistry, and they do a lot. I think regionally, all of them have telemedicine connections. The capacity, that we're talking about at School-Based Health Center isn't quite there yet, but that is an option to a certain extent. So I think what we need to do as a state is invest in creating systems of care for children or adults, for that matter, where you actually have providers at these sites. So one of my dreams is that we have a provider in a school, either through FQHC or through a hospital system or through whatever, that someone funds that, and that provider serves as that link, serves as the system of care, and then they use telehealth as that link to branch out to other sites or also to other subspecialties or behavioral health services. But I think we need to find a way to place providers in these counties, whether it's a nurse practitioner or a PA who is linked in with a major health organization, whether it's CHOA, whether it's the local hospital system, whether it's a medical provider, and then we'll be much more effective in using our telehealth to reach these children.
So the connection with the public health center in each county is not really there.
No, but some are working on it. So say, look in Lamar County. Lamar County actually has started a school-based health center through the public health department. They actually are going in doing health checks on these children, which I think is extraordinary because they have the capacity to do that. But when you expand beyond that, they're going to have to link up with someone else as well. And if there are providers, if there are physicians within the health department who can do that, boy, that would be great, wouldn't it? But you've got to develop this system of care in order to do this well.
Thank you.
Thank you,
To
Pat.
add to that, we are looking at a draft pilot program looking at telemedicine with the Lamar County Public Health Nurses. So there is a pilot program looking to explore that.
Okay, along that vein of telemedicine, our next presenter is Chez Ross, Director of Development and Government Affairs, Global Partnership, and Telehealth.
Thank you, committee, for having me. You might have some of the same questions for me after I finish my presentation, so I look forward to that. But thank you guys so much for having me. Just a quick background on Global Partnership for Telehealth. We started in Georgia in 2006. Connecting rural Georgia to physicians in more populated areas to better healthcare services and access issues in rural parts of our state. As far as school-based telemedicine centers go, I know we have a little bit of lag time. Everyone is having this issue. As far as school-based telemedicine centers go, Georgia Partnership for Telehealth has 63 centers in the state that are in 16 school districts. I gave you, this is a part of my presentation, but also you guys have a handout in front of you that has a list that kind of describes some of our school systems, as well as a map of the districts that our school systems are in. So you can take a look at that as I speak as well. I'm just hitting arrow keys, right? I'm doing it correctly? Okay. Anyway, so a lot of what has been discussed already can be applicable to telemedicine centers also. A decrease in absences in the school system for students, more access to primary, specialty, and mental and behavioral health care. Without leaving the school system, they are able to access this care through the school nurse's office. We have telemedicine units in the school nurse's clinic where students are already going to access health care. They're just able to see a physician through that school nurse, that presentation site in that office as well. This, like I said, it cuts down on absences, communicable diseases, and it is less demand on the family. I know we discussed that. Also, the cost effectiveness of having health care already in your school system, not only for the family as far as traveling costs go, reaching specialists, but also a lot of families have multiple children, and finding, child care, providing child care for those kids that are not in need of specialty services or primary care services. There's a cost effectiveness there as well. School-based telemedicine centers are not free clinics. I think that sometimes gets lost a little bit, but they are not free clinics. They are billing, the physician who is on the other end of the telemedicine is billing his insurance regularly. They get reimbursed equally to an in-person visit. The state of Georgia is a fantastic state to do telemedicine in because we have parity law here. So it is reimbursable equally. All the CMOs in Georgia reimburse equally, as well as the private insurers. We talked about cost savings already. I do want to note, I know that I don't have this in the presentation. I know we were discussing costs, startup costs, as far as health centers go. And the startup cost for telemedicine centers is very different. It's about $10,000 for hardware, software in the very beginning. And then there is a continuous connection fee within Georgia Partnership for Telehealth to just maintain that relationship with the physicians in our network. And we'll touch more about the physicians in our network and those numbers and what that looks like. But as far as communities that may not be able to afford a much more expensive startup fee to have access to health care, the telemedicine piece is a lot less expensive. And really what you're supplying is just the capability to connect. So a laptop solution, there are peripheral devices that are necessary on the school nurse's side to digitally show images of ear, nose, and throat, dermatology images. As far as mental and behavioral health, I mean, that's a very simple connection. It is basically, for a very easy way to describe it, is a HIPAA-compliant Skype call. It is not a Skype call. It is not a FaceTime call. But that is the best way to describe it because you guys know what Skype and FaceTime are. So, but it is all HIPAA compliant. It's all cloud-based, so there's no concern as far as patient data. And also, when you think about school systems, you think about providers, you think about EHRs, EMRs. We are working on a pilot program with our schools to have access to an EMR. It is an opt-in option, so we don't want to by any means add more work to our already overworked school nurses. But if that is something the school system is interested in doing, that is an option within our state. I know that you guys are probably following along, so I'm just going to forget about this PowerPoint, and we can just follow along in here. As far as sustainability goes, you can see in your PowerPoint and in the handout that I gave to you basically the funding sources for the school clinics in Georgia currently. So 46 are federally funded, and that is through HRSA funds, so through HRSA grants. And then the state has funded 9 clinics. That is through a grant through the Office of Rural Health. So those clinics have been funded through that. That's a yearly grant process, so we add schools to that number yearly. As far as county and city government, we don't have any that have funded school-based telemedicine centers. Local and regional medical centers, there are 10 that, so the regional medical center is the one who is funding these programs within the school system, and those school children are then connecting to the physicians, the specialists at the regional medical center to receive services. Local school boards 22, and then private funds is 2. And I know if you look at those numbers, you think, well, that's more than 63, but some of those are some of those school grants and federal grants are no longer in use, and the local school boards have come in to continue to sustain the funding. As far as telemedicine billing goes, I know I spoke a little bit about the provider side, so the physician is billing the same amount as they would whatever their insurance pays out now for in-person. They do the same for telemedicine. Senate Bill 183 was passed in 2012 and basically set up a system that said school nurses could work with third-party healthcare providers, allowing connections with physicians via telemedicine. So that just established that this school nurse clinic was allowed to interact with the physician, present the patient, the student to those physicians, and that was a billable service for the physicians on their end. Currently, DCH is working with AmeriGroup, one of the CMOs in Georgia, and Coffee County Schools and Ware County Schools to pilot a Medicaid billing process for the school themselves. We're really excited about this at Georgia Partnership for Telehealth because we know that this will create a funding source for those schools when patients are seen. Now, it is, you can see one of the bullet points in your notes, it is not a lot of money. It's $20.52 per student or per encounter. So if a faculty or staff member were utilizing that telemedicine clinic, it would be the same amount for them as well. But that's exciting to us because that's a funding source that wasn't originally there and just assists with that sustainability model. So they have estimated or expressed to us that that billing pathway will be in place January 2016. So that's really exciting. And we're happy that DCH is putting effort into doing that for telemedicine in schools especially. The next slide is a utilization slide. So if you look at that, you can see that primary care facilities within our network for students and for faculty. So 49 of the 63 schools are utilizing the telemedicine for primary care purposes, not only for the students, but like I said, for the faculty. This cuts down on the school's cost of absentees of their faculty members, less substitute teachers. So we find that there was a study done in one of our schools, and don't ask me how they knew that this was correct, but that UTIs were actually in the school system was a big problem with absentees with their teachers, and when telemedicine was brought in, the number of teachers being absent for urinary tract infection went down, and it was actually very beneficial for the school and cost effective. I don't have those specific data in this PowerPoint, but I'd be happy to get that to you at a later date if you're interested in seeing that. As far as primary care for students only, there are 14 schools that are only utilizing their telemedicine for students, so faculty and staff are not included in that. 2 of our schools are only doing mental health, so just psych services. Like you spoke on earlier, we have a great relationship with Children's Healthcare of Atlanta that is providing a lot of our mental health services, especially the Marcus Autism Center. And so those schools have access to that as well as med management. And then I know I skipped over the specialty care services for students, and that's 49 as well. This includes mental and behavioral health, but also, like I stated earlier, we have a great relationship with Children's Healthcare of Atlanta, providing specialty services for our school systems also. Oral health, we have 1 clinic that is in place, but the services have not yet begun. I know Erica spoke earlier just about disparities in dental hygiene and dental clinics as well in the state, and that is something that we hope telemedicine will be able to do sooner rather than later is connect to dentist from the school with a dental hygienist, and have oral care be a part of telemedicine also, so teledentistry. And then I know I spoke on electronic health records already, but you can see that there are 12 schools that are piloting the electronic health records for us currently to just see how that goes. And that is Coffee County school system. So there are 12 schools in Coffee County that are a part of our network, and they're piloting this EHR program. Just some utilization numbers continued. So the spring semester, that's a typo, it should be no, that's correct, of 2015, excuse me. So January through June, there are 421 patients seen in Georgia via telemedicine just within our school clinics. So we think that's a great number, 421 encounters happened. That doesn't mean 421 students were seen. Some of those students are reoccurring patients. So, they're having a monthly checkup with their psychiatrist, or they had multiple checkups with a specialty physician, even primary care. And right below that, it states this is primary care, specialty care, and psychiatric services. Currently in the state, psychology, so therapy services are not reimbursable, so you don't find that very often within our network. We do have one, and it's actually for adults, so it's not applicable, but they do like a self-pay model, but that's not within our school systems, but that's for therapy, so outside of psychiatric services. Just a little information on providers and presenters. So GPT has approximately 240 providers in our network. That ranges in primary care, specialty care, mental and behavioral health care. These are the actual physicians that are members of ours that have access to our presenting sites. So we have a multitude of presenting sites, but one of those is the school-based health clinics. As far as continuity of care, I know we've talked about that a little bit. We believe that we maintain a continuity of care at Georgia Partnership for Telehealth with these students. So if you think about rural parts of the state, if they are lucky enough to have a primary care provider, that primary care provider is who's providing those services in that school-based clinic. Now, if they don't, some of our counties where the clinics are don't have primary care providers or pediatricians. So we're looking to local pediatricians in the surrounding counties as well. We by no means want to take the business outside of that local community. We're hoping to enhance that local community's connection with their students and really kind of bridge a transportation barrier. So we don't want, we're not trying to connect these schools to Atlanta every time, and they're seeing Atlanta physicians that don't know their community, and there's not that same interaction or same understanding of care at that level. So, and that's my very next point that you can see. So we are looking to surrounding counties. As far as training goes, all providers and presenters are trained on the telemedicine. It's different than an in-person connection. You're utilizing peripheral tools to make sure that you are seeing, the earache correctly. There's a Bluetooth stethoscope, so physicians are able to hear heart, lung sounds, bowel sounds through Bluetooth technology. I hope that eventually we'll be able to kind of show you guys some of these technologies in one of the committee meetings so you can maybe see and understand for yourself how great of a tool these are. They are definitely equal to or superior in some cases to in-person encounters. The Composite Medical Board has rulings out that telemedicine cannot be utilized unless it is equal or superior to, and our GPT follows along those lines very carefully to make sure that what we're doing maintains that. Connectivity concerns are always a concern. I mean, we're experiencing today that technology is not always your friend, and sometimes it doesn't work correctly. So we definitely work within those school systems to make sure that they have proper connections, whether it's through wireless connectivity, but a lot of times we prefer a dedicated line, a T1 line, so that school has dedicated connectivity no matter what's going on, or if the library or there's a somebody's pulling a lot of data and now the school nurse can't project the student to the physician. That's a horrible scenario that we don't ever want to happen. So we definitely ask that it is dedicated to the school nurse's clinic, to the telemedicine clinic. As far as the presenter, we actually, in our school systems, it has to be a registered nurse, an LPN, or a CNA to present patients. That is our own GPT's own standard. That is not the standard within the state, but our standard is it has to be a medical professional to present a patient. And a great example of that is legally I could present a patient to a physician and they could bill for that service. That's totally legal. But if that physician asked me to listen to the apex of the heart, I have no idea what he's talking about, and it doesn't really do for the patient for me to be the one presenting. So we want that to be a medical professional. And then my very last page is just models. I know you guys were talking about seeing clinics in person. These are some clinics that we think are great clinics that are doing telemedicine very well. Some of these overlap with Dr. Johnson's clinics. Some of them are their own freestanding telemedicine clinics. So we definitely, if you guys are interested in going on a tour, I know that we would be happy to do that with you. So do you guys have any questions for me?
Okay. Chez, thank you very much.
You're welcome.
Thanks for bringing this important tool to us. One question I had.
Sure.
You mentioned about allowing school nurses to interact with third party. In your system, are there any of the nurses that have standing protocol agreements with providers?
So the school, I think I'm answering your question correctly. If not, I apologize. The school has agreements with the providers. So both sides have a memorandum of understanding with each other. Okay. And just like they were talking beforehand about parental involvement, there's a great parental involvement with this as well. There has to be, history, paperwork, forms filled out at the beginning of the school year to allow students to be a part of this program, as well as if their child is seeing a physician through the telemedicine clinic, the parent is, we always encourage the parent to be there in person if they would like. Obviously, there are situations where that is not available, so that parent is notified as well that their child is going to be seeing the physician. Did I answer is that the question that you're asking me as far as the school having?
But would be somewhat standing orders or protocol agreements so that not necessarily through telehealth, but they may have a protocol agreement with a local provider as far as certain acute
Sure. Yes, they do. And like I said, especially when it's a local situation where that provider is local, they do have agreements with them, and they have agreements as well with the pharmacies.
Mm-hmm. Okay. All right, good.
Representative Gardner has a question.
Okay. Yeah. Okay.
Thank you, Mr. Chairman.
Thank you for letting me ask questions.
Sure. Certainly.
I am curious about what the barriers are. I'm particularly interested in the behavioral health, the paucity of providers, particularly child psychiatrists. I mean, what are the barriers to using other providers? For example, a clinical psychologist who regularly treats children, or a social worker who regularly treats children.
The barriers as far as telemedicine is concerned, or?
The billing, I suppose.
So, sure. So currently the state has not allotted that those are billable services. So
the state Medicaid department?
It is.
Or state, yeah.
Mm-hmm.
So, and it is that psychiatrists, nurse practitioners, and psychologists can do ongoing therapy, but licensed clinical social workers cannot do ongoing and be able to bill for reimburse.
So advanced practice nurses, psychiatrists, physicians, and psychologists can be reimbursed for their services at the other end of as they observe the behavior. Yeah. Sure. I hear that it in some ways kids who are more used to being online and making systems like this work really do well in this environment to be revealing about what's going on. So.
And like I stated, it is legal to, go through therapy sessions or family therapy via telemedicine. It's just more of a self-pay model.
Mm-hmm. So what's missing is clinical social workers.
Mm-hmm. They can do an initial diagnosis, but they can't provide ongoing therapy and bill for. I mean, they can legally, but it's not a reimbursable service.
Correct.
But the other three are.
Mm-hmm. And we can get you that information.
Thank you.
As well.
Thank you.
Any other questions? Buddy? Okay.
Thank you
Shay,
very
thank
much.
you for your presentation. We appreciate you being here. We've got two others that have signed up to comment. Brian Williams with Emory University.
I promise not to use PowerPoint.
Okay. Just introduce yourself. And
I'm Brian Williams. I'm an associate professor at Emory University. My appointments are in public health and in nursing. Let me first say I'm not a nurse, but I have a lot of friends that are nurses. The great thing about being in the School of Nursing is we have private bathrooms when you're male. So there's only 3 male nursing faculty. It works out pretty well, actually. I wanted to talk to you a little bit about the research and really provide the foundation for why these types of services are needed. And a number of our speakers have talked about the nuts and bolts of how you actually provide the services, the logistics, and that type of thing. But what I want to do is I want to impress upon you the desperate need that I think we have for health centers and health services in general in this state. Across the nation, we're talking about an increasingly sick population entering the schools. I worked in a children's hospital in Memphis for 7 years, and it seemed like every year the children coming in our hospital looked worse and worse. Adult onset diabetes when they're teenagers. When we think about the increasing prevalence of chronic conditions, the area that I work primarily in is children who are born prematurely. Let's take prematurity for an example. In my own work, we've demonstrated that a child who's born before 32 weeks is 2.5 times more likely to fail that 3rd grade test. And that's here in Georgia. Now think about that. 2.5 times more likely to fail the math and the English test simply because they were born prematurely and the conditions associated with that. So we're not talking about children that are getting sick while they're in school. We're talking about children who come to school already with a lot of predisposed conditions that make them sick and make learning very difficult. We talk about 3rd grade reading here being a public imperative, and the governor's talked about this. Well, it goes hand in hand. If it's a public health imperative that children read, we also have to make sure that children are healthy to read, and that's one of the pillars that we talk about in 3rd grade reading. The other problem that we run into in this increasingly sick population is we don't know a lot about them. Any of you have family members that are teachers? My wife's a teacher. She teaches 3rd grade. My mom was a Head Start teacher. You think about, what does a teacher know about a child's health? Just about their general condition. So there's no opportunity to interact with a healthcare provider in many instances unless it's some sort of acute issue. So for the most part, we don't know a lot about them, and these types of services provide that feedback, and centers provide that feedback. The other thing is, when you think about morbidity and the increasing face of morbidity in the public school health sector, it's not fair, is it? It's not equitable. You think about prematurity, for example. There are school districts here that will have in excess of 1/4 of the population that go to that school who were born prematurely. Whereas some school districts, it might be 8 to 9%. So I tell people, I can predict your test scores based on your birth distribution as much as you can by characteristics that they might have educationally. So it's something that, again, we need these types of services. If it's not fairly distributed, the burdens on the schools themselves are not fair. And so some schools, and it's obviously ties in with poverty, as many of you have mentioned. I do like nurses a lot. I think advanced practice nurses bring a lot to the table. I think nurse practitioners bring a lot to the table when it comes to providing these types of services. One thing I urge you to think about with nurses is that they cut across every subspecialty. And so nurses are ideally suited to provide and to coordinate telehealth services. They're ideally suited to provide education. I'm amazed by the broad-based skill set of nursing when it comes to playing this, and they're a viable workforce. You know, Emory is a top 10 program in nursing, but We're also one of the few top 10 programs that train undergraduate nurses. We're training and turning out nurses to do exactly this, to have BSNs, to be able to provide these types of services. The other thing I want to mention just briefly is we've talked, and we're starting to talk here a lot about health or climate in schools. What is climate? And if you look, last year we released the latest STAR climate ratings, and I like the theme of climate, and Dr. McGivney will talk about climate as kind of the canary in the coal mine. That when climate goes down in a school, you can see other indicators in academic achievement start to decline. Well, what makes up climate? Well, we have elements that we're talking about now, but it's hard to deny that a healthy population is not fundamental to school climate. And so if you're going to have a good school climate, you have to have healthy kids. And I think school-based health centers do that. I was at a meeting on Friday that all of us go to meetings all the time, but it was really a groundbreaking meeting. We were with AmeriCorps, and we were talking about foster care children, and the Commissioner of Health and Commissioner of DFACS, and all these folks were in there talking about how we solve the problems when it comes to school-based services for foster care children. And we all agreed that this is not just relevant to foster care children, that when we talk about providing health care services on site in this context, it benefits all children. And it's not just going to benefit children in poor schools. I think it's going to be a foundational part of what we see in schools across the state. In the 1990s, I was involved in a number of efforts in comprehensive school health education programs, and I was part of the School Health Standards Task Force and things like that, and it kind of fell off. But I do see renewed excitement because of the problems that we do have, and I urge you to work with us, and any information we can provide you, we'll certainly do so. So I will stop right there. I wasn't prepared to speak. So.
Okay, Brian, I appreciate your insight and bringing the insight to the committee. Appreciate you being here. Okay, we've got Ellen Jager with Mental Health America, Georgia. Ellen, thank you for being here.
Thank you. I also would like to make a few comments, but my comments are very specific about kids in the system who have a diagnosis of a mental health issue, more likely have a mental health issue, but do not have a diagnosis. So what we know is that a lot of the kids that show up to speak to a nurse or a school counselor are talking about physical aches and pains. They're talking about real stomach aches, real headaches, real distress that they can only describe in the way we think about health most of the time, which is physical. There's so much stigma against children who do have mental health issues that that's not typically what a child would recognize in themselves. However, more importantly, it isn't what parents recognize either. Parents have a very difficult time distinguishing between what would be a typically developing child and a child who is in the process of developing a mental illness. We know that there are best practices that can help, like youth mental health first aid. There is a combination of funding, a little bit from the state, a little bit from the feds, but not enough to go around. So if you take the stigma and you take the lack of knowledge that we know about mental health versus a typical development, there's a real issue here in helping the schools, because we are protecting our kids, we believe, by not talking about mental health issues. There was some discussion, or certainly a mention on your sheets about EPSDT, and what we know about that, although the Medicaid reimbursement for the state is quite good, as children get older, they utilize the services less and less. I think part of that is the challenges become greater, the providers become fewer, and we're just seeing a horrible underutilization of EPSDT. There needs to be real clear definition of what everyone's role is. What is the role of a school nurse? What is the role of a school counselor? In most cases, school counselors maybe 20-25% have any kind of mental health background at all. Yet in many schools, they're it. They are the professional in the school. Nurses, unless they did specialize in mental health, were taught many things and can help a kid with diabetes, but may not be able to help a child who has a mental health crisis. We need to start looking at these kids at a much, much younger age than we are presently. We cannot talk about middle school and high school and expect a good outcome. We need to be talking about school kids before they even get into kindergarten. We know here in Georgia, kids as young as 5 have suicide ideation. We know here in Georgia, an 8-year-old took their life. We also know that that's not acceptable, nor the outcome that we want. We want our kids to be much healthier. We haven't really learned to ask the right questions. I think we're afraid to ask the right questions. I think we're afraid to actually say to a child, are you thinking about taking your life? But in many cases, it is the only question that will save that kid's life. We have to start looking at health as behavioral health integrated with physical health, and behavioral health would look at substance use as well. We know that kids start using at a very young age for many, many reasons, whether it's because it's available or whether it's because they're trying to heal themselves. Children with mental health problems look for a way to self-medicate, and unfortunately there is an endless supply for them to do that. We have to really start talking about kids with mental health issues in a different way. We have an image of a child who has a mental illness, and can I just say, in a lifetime, 1 out of 5 people will have a mental illness. So we're talking about all of us. I can tell you're talking about me because I was diagnosed at 16 with my first mental health diagnosis. But we have an image of what this child will look like, what they'll present. And that is a child who's going to cause chaos, disruption, all kinds of behavioral problems in the school setting that the schools have challenges in dealing with. But many of these children are very quiet. Many of these children very quietly cut themselves, burn themselves, hit themselves, do all kinds of things that we can't even imagine because they are so desperate and looking for a release for how to deal with their own mental health issues. We have to start looking at peers because it is truly a peer movement that can make a difference. And by peers, I mean another kid, another parent who actually knows firsthand what it's like to have a mental illness and has come out on the other side and is living in recovery. And I'm telling you all of this because what we're looking at, the school-based health centers, are essential to children's health, but it's also essential that you look at who is qualified to provide the mental health service. I have great respect for everybody who works with kids, the teachers, the counselors, the nurses, everybody. But I also know the challenge of mental health is often not one that's met. So thank you very much for your time.
Ellen, thank you for your comments, especially on this important subject. I think as we move, is anyone else, no one else had signed up, is anybody else that wants to make any comments? Anyone else? Be glad to welcome you for your comments and your input. I think what we've learned today is that for school-based health clinics to be successful, it's a collaboration, and that it's got to be on a local level, that it has to be an impetus from need on a local level to do this. And it's all the relationships with all parts of the total health of the child, mental as well as physical health. And that that's very, very important, that it's a collaboration and that you've got all the stakeholders in the community together, working together to improve the overall health of your total school student population. I think that's very, very important. All right, any other comments from anybody else on the committee? Demetrius, you got any comments? Buddy? No. Okay. Again, welcome any other comments from any of our guests. I appreciate your interest in being here. Dr. McGibney, I appreciate your interest from the Department of Education in being here and we'll be in contact and see what we can do from that standpoint. Erica and the other presenters, I appreciate it very much. Pat, you got anything else?
No, it's very exciting, and it fits very well with the study committee that I'm on, which is looking at children's.
Okay, good, good.
Sounds like it. Okay, thanks.
Okay, I think Erica said that we may have some national folks here maybe on the 29th of September. If we want to look at that as a possible other date, I don't know. We'll sort of put that on the radar, and that could give us a little bit more of a national perspective. We'll put that on the radar. And again, if you've got any of these centers in close proximity to your district, I'm going to make an effort to go to Tiger Creek. That's right up the road from me between now and our next meeting, and see what they're doing there. But we'll sort of pencil in the 29th perhaps as a possible date. And then I hope we can have maybe one more joint meeting, and then one more, and then finally finish up and put our report together. I think our target date's December 1 to have the report ready for presentation. Again, I appreciate everybody here and their interest. If you've got comments or questions, or other things that you'd like for us to explore, make sure you're on our email list with my assistant Christy or with Courtney, either one, and we'll keep you informed as far as our progress on this adventure. I think we've been productive today, and have got a wealth of information, a good foundation to look at and work from, and I think we can all safely say that this is a worthwhile project to move forward and see if we can expand it throughout the state. Again, thanks to my presenters, and appreciate your interest. Thank you.